Dr. Sumedha is unable to join today. She's just a little stuck with some traveling, so she'll not be joining today.
Ma'am, can you just ask Nand Kishore to just display one slide?
Ma'am,
How's it
we are live.
We can go live. Okay. Dr. Gunjan, please initiate.
So, a very good evening to one and all. So, before starting with the session, I would like to introduce our respected Sangeeta Dheer ma'am. So, Nand Kishore, could I have the slide for Sangeeta ma'am? So, Dr. Sangeeta Dheer did her master's in periodontology from College of Dental Sciences, Davangere, Karnataka, and clinical externship program in implantology from University of Birmingham, United Kingdom. She has been credentials by the International Congress of Oral Implantology as their fellow ex-core committee member, National Oral Health Program, Ministry of Health and Family Welfare. She has served Indian Society of Periodontology in various capacities, has been ex-vice president, executive committee member, national convener, prenatal periodontal healthcare committee, assistant editor, and journal of ISP. Ex-editor-in-chief, Journal of International Clinical Dental Research Organization, has been KOL to various oral pharma companies, was the organizing secretary of the first national symposium in India on periodontitis and diabetes. It was a collaborative event of RSSDI and ISP. She has numerous scientific publications, chapters, and has been keynote and guest speaker at several dental and medical conferences, meetings on national and international forums. We welcome you, ma'am. Over to you, ma'am.
Thank you, Dr. Gunjan, for the introduction. Anand Kishore, can we have the presentation of the moderator, please? Anand Kishore?
Yes, ma'am. Yes, ma'am.
Yeah. Gunjan, Dr. Sonika is unable to join. We will have Dr. Neema as the first speaker.
Okay, ma'am.
So, Dr. Bhushan, you will be the first chairperson for the lecture. So a very, very warm good evening to the faculty, the esteemed guest speakers, the delegates who have all joined together. Greetings from the Diabetes India Oral Health Group. Next slide, please. So that's the dynamic head office of Diabetes India, Dr. Aravind, Dr. Sabu, Dr. Reddy, and Dr. Amit Gupta. Next slide. And that's the equally competent, dedicated team of our Diabetes India Oral Health Group. Some of the members are already there on the podium today. Next slide, please. So this is something just to sensitize before we get into the grind of the topic. We are all aware of these array of, tablet that we're seeing on the screen. Some things which we are aware, and we take it forward from here. The next slide. So a few statistics to be dug in. Systematic analysis of the global burden of disease study published Lancet 23. Next slide. What does it say? The Indian origin sits at the prevalence up to 2050. They have projected to up to 6% of diabetes. Next slide, please. Now, when we compare this to the national burden of periodontitis published JCP, next slide, please. What do we understand from this publication? 1 billion predicted cases of periodontitis globally. 2019, age standardized prevalence to up to 8%. And the severity is going to be increasing for the past 3 decades. And what is the statistics for the Indian scenario? Last published 2019, it has saying that up to 87% we have diabetic population, of which gingivitis and periodontitis is equally proportional, and complete tooth loss we are expecting to up to 11%. Next slide, please. Now, the 3 studies we are just trying to portray here. Concern is about diabetes, and equal concern goes to about pediatric diabetes also. And there is a high prevalence of periodontitis which has been reported in the population. We are also aware the high prevalence of pre-diabetes in adult population. Alongside, there's one study we are showcasing here, which is talking about the the nature and behavior amongst the type 1 diabetic as well as the non-diabetic population. So next slide, please. So this is the disease burden. Now let us understand what is the economic status of such countries who are suffering from such burdens is going to be talking about. So UK as well as US literature talks about some sort of a compilation of the insurance companies and the data that they dug out. They said that the pandemic or an epidemic of diabetes is going to be there, but that is a more tortuous course to treat, and it's going to dig more on the economic levels of the person's day-to-day earnings that the person is having. Vis-a-vis, why don't we undertake a thorough periodontal assessment and treatment for the population, which is going to be otherwise reducing the overall outpatient healthcare cost in the country. So what is going to be expecting as a practical implications? A healthy mouth is going to be helping us and playing a key role in the diabetes management protocol. That is what we are looking forward to. Next slide. With this positive note, we'll be getting started to the scientific evening for this webinar. And we are going to be starting with the lecture 2. The lecture 1 speaker is facing a little trouble in logging in. So can we have the chairperson, Dr. Anu Bhushan, slide Nankishore, please? Dr. Anu Bhushan, second chairperson. Nankishore?
Yes, ma'am. Yes.
It's an indeed privilege and honor to introduce the first chairperson of the day. As the first chairperson, he was the second person, but we are doing it as first chairperson, Dr. Anu Bhushan. He has served as professor and head of the Department of Periodontics at Santosh Dental College, Ghaziabad, till 2015. He's an ex-alumni of the prestigious King George Medical College, Lucknow. At present, he's into full-time dental and specialized practice at Ghaziabad. So what are his credentials talking about? He was former advisor of UPSC. He was advisor, Nankishore, the slide. Advisor and member, full slide, please. He is advisor and member of the management committee of the dental colleges and voluntary organizations. Full slide, please, Nankishore. He was a former president, Indian Dental Association, Ghaziabad. He has also served as a former vice president and active member of Indian Society of Periodontology. He was a member of editorial board, Journal of ISP, Journal of ICD, India section. He has an academic achievements, which is talking about multiple guest lectures and keynote lectures to a number of conferences. He has been a co-author to a leading textbook of periodontology and a guide and a supervisor to several dissertations and researches. External examination for postgraduate courses for a number of medical universities to his credit. He has extensively spoken and delivered motivational lectures to public on the importance of oral maintenance and its relationship with medical conditions, especially diabetes. And over to you, Dr. Anu Bhushan. And before we just initiate the next speaker, we have Dr. Amit Gupta, the Joint Secretary for Diabetes India, joining us. Can we have Dr. Amit Gupta? He's joining us from Amsterdam. He's not in the country, so it's good to have you over, Dr. Amit Gupta. Welcome, sir.
Yes, thank you, Dr. Sangeeta. And I'm really happy to see this webinar happening on diabetes and oral health. And welcome all the speakers and faculties and all the participants who are attending this webinar. So I will not be interrupting you, and please proceed with the webinar. Thank you, Dr. Sangeeta, for having me.
Thank you, and have a great meeting at Amsterdam. We'll catch up later.
Thank you.
Thank you so much for joining.
Thank you, Dr. Sangeeta.
Thank you. Bye-bye. Bye. Dr. Bhushan, could you please introduce the first speaker, Dr. Nima Rai, please? Nankishore, Dr. Nima Rai.
Yes, ma'am.
Over to you, Dr. Anu Bhushan.
Good evening, everyone. Welcome Professor Dr. Nima Rai. She is a professor and head of Department of Periodontics, Pacific Dental College and Hospital, Udaipur. She did her graduation from Yanapoya, Mangalore, and post-graduation from Pacific Dental College, Udaipur. She has an academic experience of 15 years, undergraduate, and 11 years of PG teaching experience. She has a good number of publications amounting to 49. Welcome, Dr. Nima Rai.
Thank you, sir. I was of the impression that I am the second speaker.
You were actually, but the first speaker is having a little struggle in joining. So let me just track where she is. So meanwhile, you please start off. Huh? Dr. Nima Rai's presentation, Dr. Nankishore.
Yes, ma'am.
Yeah.
Right. Okay.
He will share. He will share.
Okay, but then he has to change it every time, no? Like,
Tell him. Don't worry. Don't worry.
I'll try sharing myself.
Now, should he share or will you share? Stick to one thing.
No, I tried time once, yeah.
Okay. Nankishore,
that
2
will
मिनट
be-
रुक जाइए. 2 मिनट रुक जाइए.
Yeah.
उनको करने दीजिए.
Ma'am.
Because it's easier to change slides this way.
Yeah, great. Just make it full screen, bus, and then you are
Yeah.
ready to go.
Yeah. Hope it's visible, ma'am.
It's visible. Kindly make it full screen.
Okay, showing full screen in mine.
Just go on the bottom and just click the white TV screen there because that will just blow up. Bottom
Yeah,
left,
that
right.
and it's showing the full screen in my
And Nima ma'am, hello.
yeah.
Ma'am, you go back to share again and share the entire screen.
Yeah, I've done that, sir.
Share again and share the entire screen. Then you click on this PowerPoint presentation full screen.
I'll escape and then do it again.
Yeah.
Good evening, Sadhurag. So it's a long time meeting you. Is it still not coming full screen?
No.
No,
Just
ma'am.
quit. बाहर आ जाओ आप डॉक्टर नीमा
Quit.
एंड दोबारा से शेयर करिए.
Yes.
Stop sharing.
हाँ, आप दोबारा शेयर करिए.
Okay, I think last time I had a problem. He told me something. I don't remember what yet.
Share and share the full screen, ma'am. The
Share.
entire screen.
Yeah.
Yes.
आ गया.
Yes.
Perfect.
Yes, no, it's fine.
Please
Okay.
start. Huh?
Yeah. Very pleasant evening to one and all present here. And but I'm not able to go to the next slide in this month.
You just shift the page down. I think that will do.
Yeah, the page
If I'm not
down
wrong.
is doing. I'm doing it, but it's not going down. I guess I'll allow the person to share them. I am not able to go to the next slide in this. Yeah. Is it visible now, ma'am? Is the
Yes,
next
ma'am.
That's okay.
yeah. So the topic is gingival trabecular blood, which is used as a non-screening tool for diabetes mellitus in dental clinics, which was my thesis topic, which was done about 15 years back. So the topic is revisited now. I hope I'm audible also.
Yes, you're audible.
Okay. So diabetes mellitus, as we all know, comprises a group of metabolic disorders that share the same phenotype of hyperglycemia. And several distinct types of diabetes mellitus exist as type 1, type 2, gestation, etc., caused by complex interaction of several environmental factors and lifestyle choices. Depending upon the etiology of diabetes mellitus, factors contributing to hyperglycemia might include reduced insulin secretion, decreased glucose usage, or increased glucose production. Now, diabetes mellitus is often asymptomatic in its early stages and can remain undiagnosed for many years. And the screening can lead to early diagnosis and early intervention, which can prevent long-term complications. And because of the association or the two-way association between dental infections and diabetes mellitus, and because the presence of one promotes the other, dentists are extremely likely to encounter an increased number of undiagnosed diabetic patients in their clinics. So the self-monitoring devices, which are easily available in the market, are a simple method for self-monitoring, but require a needle puncher to obtain the drop of blood. So to counter that, the development of painless and non-invasive methods are continuously being developed. And so our effort in the past few years, many have been done and none are in routine clinical practice. Right now, we do have those self-adhesive patches. But anyways, what we tried to do was when we probed in a dental clinic, which is routinely used, the oozing blood from the sulcus, that was used for the non-invasive or minimally invasive monitoring of the blood glucose levels instead of finger puncture. And we tried to correlate the two values. So the objective was to assess the glucose levels in the gingival clavicular blood, which was oozing out during probing, and to correlate that with the blood glucose values determined by finger puncture method, both in diabetic and non-diabetic population, and to establish if gingival clavicular blood can be used as an alternative or non-invasive alternative for the finger pincher method during routine periodontal examination. The study involved 50 diabetics and 50 non-diabetics in the age range of 26 to 66 years. Non-diabetics were in the 20s and diabetics were more towards the 60s. Inclusion criteria, all diabetic patients, study group included the diabetic patients and control group included the non-diabetic patients, both with moderate to severe gingivitis, who had at least one tooth in the maxillary anterior region that showed bleeding upon probing. So the maxillary anterior was selected since that was easier to collect from the sulcus. Exclusion, any requirement of antibiotic pre-medications or subjects undergoing treatment for polycythemia, anemia, gout, dialysis, or any other disorders that were causing an abnormally high or low hematocrit. And also subjects taking supplementary vitamin C that might interfere with the glucose test strip oxidation reaction. Subjects with systemic diseases such as severe cardiovascular, hepatic, immunological, renal, hematological, or any other organ disorders. And also subjects on medication that interfere with coagulation like anticoagulants or analgesics like aspirin. Clinical parameters included gingival index to assess gingival status, and oral hygiene simplified was used to assess the oral hygiene status. And mainly gingival clavicular blood glucose and finger stick blood glucose values were recorded by using a AccuCheck self-monitoring device. Now for site selection, as was discussed, gingiva around upper anterior teeth was chosen for the gingival clavicular blood sample. And before collecting, supra and subgingival scaling was carried out to facilitate collection of the blood. Also, contamination with saliva was minimized by using gauzes and air drying. And then Williams periodontal probe was used to probe the anterior teeth, and sites with profuse bleeding were preferred, and while sites with suppurations were avoided. Now, instead of directly collecting the blood, we use small capillary glass tubes for collection, and also the blood was later blown out using chip blower. Afterwards, finger stick blood was collected regularly by pricking with a lancing device, and both samples were taken at same visit, and later they were recorded and tabulated for statistical analysis. So this was the armamentarium used for probing and AccuCheck self-monitoring device with the strips. So here we have used capillary glass tubes we have introduced into the sulcus after probing so that the blood enters into it through capillary action. And again, to minimize any contamination, chip blower was used to blow out the blood into the strips. This was all to avoid contamination with saliva debris. So this was additionally used. Finger stick was routinely done with a lancing device, and glucometer was used as the blood glucose. Now, statistical analysis, in addition to mean and standard deviations, student independent t-test was performed to check the significance between the two values, the gingival clavicular blood glucose and the finger stick blood glucose. And also Carl Pearson's product moment correlation we used for both diabetic and non-diabetic groups. This was the master chart we used. So age and sex distribution, more in the 30s to 60s. Younger age group was more non-diabetic, and 61 to 70 were more diabetic population. So when the student t-test was applied between gingival clavicular blood glucose and the peripheral blood glucose, the significance p-value came to be 0.129, which is non-significant in diabetic, and also in non-diabetic it was 0.503, again was non-significant. So consistently what was seen was peripheral blood glucose, 218 was the mean, was a bit higher than the gingival clavicular, which was 193 in the diabetic. Whereas in non-diabetic, we saw 104 was mean value for peripheral plastic glucose and 97 was gingival clavicular blood glucose. So in both the groups, gingival clavicular blood glucose showed consistently less than the peripheral blood glucose. This might be due to the saliva or the GCF contamination of the blood in the oral cavity. So same thing, the graphs, we saw the blue showing peripheral blood glucose, which was consistently higher than the red bars, which were showing peripheral blood glucose. This was for diabetic, and this was for the non-diabetic group in all the 50 patients. So Carl Pearson's product correlation was done to check correlation. We showed correlation of 0.9 approximating to 1 in both diabetic and non-diabetic population. So this, when we did a regression line and scatter plot, it showed a linear relationship between both the gingival blood and the peripheral finger stick method, showing both the values were almost similar and non-significant. So same, this was for the non-diabetic group. So since diabetes and mellitus has a two-way relationship, consistently some of the other studies we do try to see. And the periodontist frequently manages diabetic in the dental clinics using limited information about their blood glucose control. Usually, the only information available is from a single laboratory test that might not reflect the current blood glucose test. Of course, nowadays we do have glycated hemoglobin, which shows their long-term control, but most of the time they do not have it, and they just come with the random blood glucose or fasting blood glucose done, which is done some time back. And monitoring their blood glucose during office visit might be a better alternative for that. And periodontal inflammation as such is known to produce ample extravasated blood during your diagnostic procedures. Simple probing will lead to blood, and that blood can be used to check the blood glucose levels. So, and glucometers, if available in the clinics, it can, using this technology of portable glucose monitors, the gingival clavicular blood can be checked for the blood glucose monitoring. That was what we're trying to see, especially for chronic periodontitis patients, long-term maintenance, if they have to undergo surgery and in such cases. And in this study, this gingival clavicular blood was checked with a peripheral finger stick to ascertain if the former relates to the latter, and thus if it could serve as an alternative to measure blood glucose. And the correlation can be influenced by a variety of factors such as site of sample collection, sampling methodology, type of instrument used, and also duplicate sampling. So in the past also, this intraoral blood glucose studies have been done by Steen and Nebbia, Beckler et al. In 2002, and Kada et al. At 2006. They have transferred blood onto the test tip directly from the oral cavity itself. But we have avoided that to avoid contamination, since this can lead to hemorrhagic more blood in the test strip itself, or by rubbing blood onto the strip from blood lead, and dental curate also has been tried. But this rubbing or direct wiping will not produce a uniformly timed reaction and might damage the strip's chemical indicator surface. Also, significant contamination might occur from saliva or oral debris present at the wiped gingival area, or from plaque and crevicular fluid on the dental curate. So in the present study, we avoided all this, and we try to keep it as contamination free as possible by isolating the bleeding site with gauze after scaling, and also using a capillary tube for collection of blood. And also the chip blower was used to further maximize dilution with saliva while blowing out blood from the tube onto the glucometer. So the regression line and scatter diagram showed that it was a linear relationship between both finger stick capillary and the clavicular blood, which was plotted for both diabetic and non-diabetic groups. And this correlation values obtained were very close to the previously obtained values by Parker or Beckler or Kada et al. So additionally, students' independent t-tests also showed no significant difference between the gingival clavicular blood glucose and the peripheral finger stick blood glucose in both diabetic and non-diabetic population. So clinical application of these findings involves interrelationship of diabetes and periodontal disease, since we might find many diabetics in the periodontal clinics because of the interrelationship. And usually a patient comes with a single result. Since periodontal disease requires long-term maintenance that often continues for years, this single blood glucose might be insufficient for the patient management. So using the method described in this method, we can rapidly measure blood glucose many times during a surgery at the beginning or hours later on, using gingival clavicular blood, which is present in the oral cavity itself. So multiple measurements are possible with this, which allows the practitioner to better assess the patient's diabetic control as the treatment progresses. Apart from this, suspected diabetes can also be screened in the dental office itself and then referred for further investigations if required. However, there are some disadvantages like high possibility of contamination, especially from plaque, gingival fluid, debris, and the saliva present. These all might limit the use of gingival clavicular fluid for estimating the blood glucose level during routine periodontal examination. Also, one more thing is we advise the patient to have food before coming for surgery. So the fasting blood glucose might not be possible. So further investigations employing a larger sample size and comparing the capillary glucometric values with laboratory venous blood glucose should be conducted to establish gingival clavicular blood as a reliable source for diabetic screening as well as diagnosis. That was the study, and as a summary and conclusion, we show it was seen that there was no statistically significant difference between gingival clavicular blood glucose and the peripheral finger stick blood glucose, which was true for both the diabetic and the non-diabetic groups. There was a positive correlation between both the measurements. Yeah, that was about my study, which has been published in just around the year 2011, I guess. Thank you, ma'am, for this opportunity.
Thank you, Dr. Nima. It was, if you say it's an old study, but it still holds a gold standard, because when we talk about invasive and non-invasive, that's a big debate. And possibly once we finish towards the tail end, Dr. Anurag is going to taking it up as a one by one from all the talks that we are having. So thank you so much, Dr. Anubhushan, Dr. Nima, for the wonderful session. Now we get on to the next talk. And may I invite Dr. Gunjan Gupta. Can we have her presentation as well, the introductory slide? Nankishore?
Yes, ma'am.
Dr. Gunjan Gupta, introductory slide.
Yes.
Okay, now we have the next session to be chaired by young dynamic Diabetes India oral health group member, Dr. Gunjan Gupta. She is a professor and head at ITS Dental College, Greater Noida. She has an academic and clinical background spanning over 12 years and a consultant periodontist at various clinics in Delhi and NCR and owns her private practice. She conducts various workshops on implants and mucogingival surgeries and lasers. She has numerous national and international publications to her credit. She is a live member of Indian Society of Periodontics, Federation of Dentistry and Indian Dental Association. She serves as a assistant director in collaboration with the Federation of Special Care Dentistry, supporting initiatives such as Special Olympics. She is honored with the Global Professional Award in the year 2022 for excellence in contribution to periodontology. She also has a keen interest in periodontal medicine, specifically diabetes and periodontics, and has got various dissertations conducted on this topic, and also is a content developer for JP Publishers. Over to you, Dr. Gunjan, for introduction of the next speaker, please.
Thank you so much for this introduction, ma'am. Nankishore, can we have the presentation for the next speaker, Dr. Sonika?
Introductory slide.
Can we have the introductory slide?
Introductory slide, Nankishore, Dr. Sonika.
Yes.
Yes, Dr. Gunjan, please.
Yes. So it's my honor to introduce Dr. Sonika. She did her BDS in the year 2017 from CSI College of Dental Science and Research, Madurai, and MDS in 2021 from KSR Institute of Dental Science and Research, Perunchugode. Membership, she is a member of Indian Society of Periodontology, and she has various publications, around 10 publications in various national and international journals. We welcome you, ma'am. Over to you, Dr. Sonika.
Thank you, ma'am. Thank you for the introduction.
Nankishore, Dr. Sonika's presentation.
Yes, ma'am.
Shall I start, ma'am?
Yes, please. Yes, ma'am. Please start.
Yes, ma'am. So can you go to the next slide, sir? Sir, next slide. A very good evening to each and every one of you who have gathered here virtually in this platform to listen to the recent updates of the Indian studies related to periodontal disease and diabetes mellitus. I feel very honored and privileged to be a part of this webinar. So I would like to share my journey of main dissertation through this platform. So next slide. So as you all know, periodontitis is an inflammatory disease of the periodontium that arises as a result of host immune response. Whenever the pathogenic microorganism invades, our host immune cell recognizes it and fight against it. But how does the immune cell recognize the pathogen? So next slide. Next. Okay. So we have some specialized receptors called pattern. So before slides, sir. Last slide, sir. So these are the pattern recognition receptors. So these pattern recognition receptors will recognize the patterns associated with the microorganisms. For example, lipopolysaccharide of the gram-negative bacteria. Apart from recognizing these receptors, these patterns, these pattern recognition receptors can also recognize the molecules which are released as a result of host immune response. So thus, pattern recognition receptors can recognize MAMP as well as DAMP. So this pattern recognition receptors can be categorized into two types. One is intracellular receptors and extracellular receptors. So node-like receptor is one of the intracellular pattern recognition receptors, of which NLRP3 is the best studied one in the literature and plays a major role in the pathogenesis of periodontitis by releasing pro-inflammatory cytokines like interleukin 1 beta and interleukin 18 upon activation. Next slide. Okay. So literature evidences have shown increased expression of NLRP3 in the saliva, serum, gingival tissue samples, as well as in the gingival clavicular fluid of periodontitis patients. So as periodontitis is the sixth complication of diabetes mellitus, we just wanted to explore whether NLRP3 is just associated with the periodontitis or else it is associated with any other systemic diseases, Next slide. Okay. So thus NLRP3 is associated with many systemic diseases, and the most important one is the diabetes mellitus. So this was first stated by Huang et al. In the year 2015, in which he found increased expression of NLRP3 in the gingival tissue samples of periodontitis patients with diabetes mellitus. So how NLRP3 is associated with diabetes mellitus is the reactive oxygen species and advanced glycated end products which are released during the hyperglycemic status can result in the activation of inflammasome. Next slide. So thus we came to the conclusion that NLRP3 is associated with periodontitis as well as the most important systemic disease, diabetes mellitus. Based on literature work, we also found that there were no studies in the literature related to the salivary expression of NLRP3 in periodontitis patients with diabetes mellitus. Next slide. So with this groundwork in our mind, we just wanted to evaluate and to compare the salivary levels of NLRP3 inflammasome related protein in periodontally healthy individuals and in periodontitis patients with and without type 2 diabetes mellitus. Next slide. Okay. So once we have the aim, we have started screening for the individuals who are entering into our OP by assessing their clinical parameters such as plaque index, gingival index, probing pocket depth, and clinical attachment level. So if the probing pocket depth is more than 3 mm and the clinical attachment loss is more than 2 mm in more than 2 teeth with bleeding or probing of more than 10%, they are categorized as periodontitis patients. So we just included periodontally healthy patients and periodontitis patients with this criteria after getting their approval, after getting their consent to get into the study. So once periodontitis patients were recruited, they were further evaluated for their systemic health. Next slide. So they were evaluated for the systemic condition. So if the patient has diagnosed as diabetes mellitus at least a year ago with random blood glucose level of more than 200 mg per dl, were categorized as periodontitis patients with type 2 diabetes mellitus. Next slide. So thus we had three groups: systemically and periodontally healthy subjects, systemically healthy periodontitis subjects, and periodontitis subjects with type 2 diabetes mellitus. Next slide. We have excluded patients with systemic diseases other than type 2 diabetes mellitus, smokers, pan chewers, and any other form of tobacco use, pregnant, lactating women, and patients who had undergone any periodontal therapy within the past 6 months, or patients under any antibiotics or anti-inflammatory drugs were excluded from our study. Next slide. So thus we finally got 42 patients enrolled in our study, which were categorized as 3 groups with 14 individuals in each group. Next slide. So once the individuals were recruited in our study, we collected the unstimulated salivary samples. So we have chosen salivary samples because it is safe, easy, and non-invasive to collect. So 4 ml of unstimulated salivary samples were collected in the morning before brushing by spitting method into a polypropylene salivary collection tube. Once the salivary samples were collected, it is subjected to centrifugation at 800 rpm for 10 minutes. Supernatant thus obtained were collected and it is stored at minus 70 degrees Celsius. So once all the samples were collected, it is subjected to sandwich ELISAT technique to analyze the expression of NLRP3. Next slide, sir. Next. Next, sir. Next slide. Okay, so this was the statistical analysis. We are done. Next slide. Next slide, sir. Okay, so coming to the results, so we have found decreased expression of NLRP3 in periodontitis patients, periodontitis with diabetes mellitus patients, whereas we have found increased expression of NLRP3 in periodontally healthy subjects. So this finding was found to be contradictory to the studies which I have mentioned in the introductory slides, whereas our study are found to be consistent with the 2 in vitro studies, which I'll be explaining in the future slide. Next slide, sir. So thus we found decreased expression. Next slide. Okay, so these were the 2 in vitro studies which stated the dysregulation or downregulation of NLRP3 inflammasome in periodontitis due to the involvement of P. gingivalis. So P. gingivalis, as you all know, is a major keystone pathogen. It plays a major role in the evasion of the host immune response. So because of the dampening of the host immune response, we have found decreased expression of NLRP3 even in periodontitis patients and in periodontitis patients with diabetes mellitus. Next slide. So we have, at present, we have no any standardized values for NLRP3, and these were found to be the confounding factors. So age, gender, and collection and any processing of the salivary samples are found to be the confounding factors of this study. Next slide. So we haven't done any correlation of NLRP3 expression with the severity of periodontitis or diabetes mellitus, and the sample size are also found to be very low. So these were considered to be the limitations of our study. Next slide. So thus, we had the future goals of doing studies in a larger scale with a larger sample size with wide range of population. And our future goals were also to determine the role of non-surgical periodontal therapy in the expression of NLRP3 and also to determine the role of or expression of NLRP3 in peri-implantitis. Next slide. So our future goals that found are addressed in the recent studies. So I would like to just highlight these 2 recent studies. So evaluation of inflammasome as biomarker following non-surgical periodontal therapy, and the second study, evaluation of NLRP3 and interleukin-18 levels after periodontal therapy. So these 2 studies have found decreased expression of NLRP3 after non-surgical periodontal therapy compared to the baseline values. So this study has stated that NLRP3 inflammasome can be decreased after doing non-surgical periodontal therapy. And this study, inflammasome, NLRP3, and AI 2 in peri-implantitis. So this is the only one study in the literature related to the peri-implantitis. So in this study also, they have found increased expression of NLRP3 in peri-implantitis patients. Next slide. So thus, I would like to conclude my study based on the literature evidences and based on the results from my study. Thus, NLRP3 can be considered as a potential salivary biomarker. It plays a major role in the diagnostic pathway as well as to monitor the progression of periodontitis. Next slide. So these are the references. And I would like to thank my guide, Dr. H. S. P. Nalini, simply giving the encouragement and support from the start of my post-graduation till now. So I would like to thank all the advisors, organizing committee members, and the members of the DIOH group. And thank you all once again for the opportunity. Thank you so much.
Thank you so much, Dr. Sonika. Over to you, ma'am. Over to you, ma'am.
Thanks, Dr. Sonika. It was an excellent study, well compiled. Thank you so much for the participation, and thank you, Dr. Gunjan, for chairing the session. We now move on to the next lecture. May we invite the chairperson for the session, Dr. Snehlata Verma. Nankishore, Dr. Snehlata Verma's introductory slide. Good evening, Dr. Ajay.
Good evening, ma'am. How are you?
All good, all good. Okay, it's indeed a pleasure to invite the medical faculty for this webinar, Dr. Snehlata Verma. She is Associate Professor, LLRM Medical College, Meerut. She has received a fellowship of UPDA, IACM and FICP. She has also been a recipient of Young Researcher Award 2022 by INC Institute of Scholar. She has also been felicitated by IPF on the Doctors' Day 2023. She is co-opted member of UP RSSDI. She is a co-editor of Punarva Hindi e-journal 2022. She is the editor of Iterative International Publishers. She is on the editorial board of NMO Journal. She is joint secretary of IMA AMS Meerut. She has been a president of NMO LLRM unit. She has various chapters and papers published in national and international journals. Over to you, ma'am, for the next session, please. Nankishore, introductory slide of Dr. Janani. Welcome, ma'am.
Please have an intro slide of our speaker, Dr. Janani.
Yeah, he's sharing it. Nankishore, Dr. Janani, introductory slide. Over to you, ma'am.
Now we have a session of Dr. Janani, and Dr. Janani is a professor and MDS Periodontology, PGHDPE, FICIOI, USA, PhD, and Professor, Department of Periodontology, Indira Gandhi Institute of Dental Sciences, Shri Balaji Vidyapeeth, Dean to be University, Pondicherry. And Dr. Janani also having academic and professional background. She has completed BDS from the RMDH and having over 10 years of academic and clinical experience with a strong passion for teaching. Who is a postgraduate diploma in health professional education, and she is a fellow of the International Congress of Oral Implantologists and currently pursuing the PhD in dentistry. And she is having areas of interest in clinical periodontology and periodontal medicine. She is the principal investigator in the 8 research project and a co-investigator in many projects, and published various papers in the national and international journals. And she has contributed many chapters in the reputed books and delivered many presentations in the conferences. And she's the chief consultant, Smile Studio, the dental clinic, Pondicherry. And she's the founder of the Instagram page. That is one of the most important things. The undergraduate periodontologist dedicated to simplifying the periodontology for undergraduate students. So welcome, Dr. Janani. And
Thank you so much, ma'am.
To have you with us in this webinar. Welcome.
Thank you, ma'am.
And Kishore, Dr. Janani's presentation.
Yes, ma'am.
I think Dr. Janani, you will be sharing it.
Yes, ma'am. Yes,
Yeah,
I am
yeah,
sharing, ma'am.
Yeah, sure, sure.
Is my screen visible, ma'am? Is my screen visible?
Yeah.
Yes, ma'am.
Yes,
Yeah.
it's okay.
Yes. Good evening to this esteemed academic group. It's my honor to present. We are being given an opportunity to present one of my passionate projects here as a part of my PhD work. And I'm even more honored to have a medical faculty here to moderate my session. Thank you so much, ma'am. Moving on, I would like to start with this quote. Oral health is more than just a pretty smile. It is an essential piece in the puzzle of overall health. I think all periodontists, we would understand this, agree with this. It all started with what was known as a focal infection theory, which led to development of a new branch of periodontology and very important and interesting branch of periodontology, I should say, called the periodontal medicine. Which basically is the pathogenesis, practice, and knowledge of periodontology, not restricted to the events only related to oral cavity, but also elsewhere in the body. Periodontal disease today now is linked to any known disease that exists, starting from the most common diabetes to arthritis to, PCOD to even erectile dysfunction. I think very soon it is we periodontists who would sign a death certificate stating that reason of death is periodontitis. You may never know. A day might come. So, as we have been seeing throughout, periodontitis and diabetes as a two-way relationship, and since periodontitis is linked to so many other disorders, but why are we so much interested in diabetes? I mean, why would even this group form? As ma'am, Sangeeta ma'am had initially said, diabetes is the focus today. It is one of the major non-communicable disease, and India is becoming the diabetic capital of the world. That is why we are more concerned about diabetes, and also diabetes has the strongest among all the correlation with periodontal diseases as compared to its link to other systemic diseases. Moving on to find, when you type in the Google Scholar to say periodontitis and diabetes, I've just typed meta-analysis. I didn't even go into other studies. It's that's some 20,000 odd results, but I know all are not, studies. It's review papers. Even if you cut it to, 50%, it's almost 10,000 studies that are done globally on diabetes. And diabetic control and periodontitis, as in like treatment of periodontitis and its effect on diabetes control. Again, some 22,000 odd articles. So many relating diabetes, frank diabetes type 1 or type 2, more of type 2, diabetes to periodontitis. But when you kind of entered pre-diabetes and periodontitis, the results were very less. And you can just see the screen. Though I typed pre-diabetes and periodontitis, most of the results turned out to be actually type 2 diabetes because it started picking the word diabetes. So I think the number of studies that are done to check the pre-diabetes and periodontitis is very, very, minimal as compared to studies that were done on frank diabetes and periodontitis. So which led me thinking that does periodontitis presage pre-diabetes? So we went ahead to formulate, conduct a study, a comparative study of the glycemic control in non-diabetic population with and without periodontal disease. And it started with this aim to estimate and compare the insulin resistant level in non-diabetic subjects. Note non-diabetic subjects with periodontitis versus periodontally healthy controls. We also checked the effect of non-surgical therapy on the parameters of insulin resistance in the non-diabetic subjects with periodontitis. So looking at materials and methods, we took all subjects like any periodontal study would, follow. The only thing is we took non-diabetic subjects. So they should also have no known systemic illness. They should have at least more than 10 natural teeth. And if they are smokers or conditions that shorten the erythrocyte survival rate, for because we have taken HbA1c as one of the parameters, or any medications that could alter glycemic control or insulin sensitivity or resistance, and overweight and obese individuals were excluded. So we divided the entire study group into two. Group A, where the case group, periodontitis, which was defined as more than 10 teeth with PPD greater than or equal to 6 mm. Because I wanted only severe periodontitis, I didn't want to check it with the mild or moderate forms of periodontitis, and BOP at greater than 15% of the sites and all the teeth sites. And the group 3 would be the periodontally healthy group with PPD less than 3 mm and BOP at less than 15% of the sites. And they should not have undergone any periodontal treatment or taken any antibiotic therapy within the previous 6 months. So the case group, we recorded the baseline parameters, PPD, CAL, and modified circular bleeding index, and the biochemical parameters, HbA1c and HOMA-IR. And all the subjects in the case group, either in the periodontitis group, underwent periodontal therapy, non-surgical periodontal therapy. And after 3 months, they were again evaluated for clinical periodontal parameters and the biochemical parameters. And in the control group, only the baseline values were recorded as it's a control and they did not, need any periodontal therapy. So the cutoff value was HOMA-IR was put at 2.5. So all the data was corrected, tabulated, and the statistical tests were done, the independent t-test, and then the ANOVA to compare the baseline values with the 3-month values in the groups. Moving on to the results. Between the cases and controls, the results are all statistically significant, obviously, because they are all periodontitis cases. But looking at HbA1c, the periodontitis cases had more HbA1c, though not to the level of classifying them as diabetics, but definitely more than the control group. And also looking at HOMA-IR, which is the cutoff rate is 2.5, but for the case group with severe periodontitis, the values were nearing 2.5, which is a pre-diabetic value, which is 2.4, whereas the controls had much lesser HOMA-IR values. Moving on to the results for after treatment, that is only the test group after treatment, there is considerable reduction in the HbA1c level, which did not come as near close to as the control group, but still definitely there was a reduction. Maybe by 6 months, if we had checked, there might have been a difference in the value much more significantly. And HOMA-IR reduced nearer to the values of the controls after therapy. Sorry. So, as I said, when you look at the literature, there is numerous studies that have found how higher prevalence of periodontal disease among the diabetic patients as compared to healthy controls. And there is also evidence that periodontal disease can worsen the glycemic control of diabetic individuals. And this association is strengthened by studies that say following periodontal therapy, the glycemic control has brought under control in diabetic patients. This idea of mine actually started as my PG thesis in 2012, wherein I just came across an article by Ulfari et al., which said that the periodontitis might, affect the general population. That study did not include HOMA-IR. Even I have published one more article with a larger sample size, but even then I did not include HOMA-IR, which was included much later during my, the days in this institute as a faculty. I continued it, and it found that periodontitis definitely produces insulin resistance. But what about it in the general population? I mean the non-diabetic but otherwise systemically healthy population with periodontitis. As I said, the HOMA-IR values, which directly gives the value of insulin resistance, was considerably higher, close to the cutoff value in control group. And it was similar to other studies, but these studies are done, higher values were reported in diabetic patients and not in non-diabetic patients. So from this, we could infer that the untreated severe periodontitis might put a person who is systemically healthy at a risk or at a pre-diabetes state. So this basically is all about the insulin pathway, where the insulin actually, kind of the insulin has to bind to the insulin receptor one, substrate one, which is very essential, which undergoes tyrosine phosphorylation and kind of phosphorylates the PI3K receptor, and then there is a cascade which finally transports this glucose transporter 4 to the cell membrane. Only if it reaches the cell membrane, this can transport the glucose into the cell. But what happens when there is a severe periodontitis is, as I don't have to explain this much in detail, as the previous presenter has explained a lot about the TLRs. The lipopolysaccharide, when it, kind of binds to the TLR, there is a cascade. Finally, there is transcription of nuclear factor kappa B, which results in increased production of various cytokines, one of which is very notorious, TNF alpha. This TNF alpha, kind of increases the reactive oxygen species. And also this pro-inflammatory cytokines acts on the same cell and produces SOX and JNK. All these acts on the insulin receptor substrate 1, and instead of causing the tyrosine phosphorylation, it shifts it to serine phosphorylation, which will block this PI3 kinase, which will prevent the transportation of glucose transporter 4 to the membrane. Thereby, the glucose cannot be taken up by the cell. This is the whole process of the insulin resistance. That is how the untreated periodontal infection, starting with the LPS, can result in insulin resistance. The same has happened in the patients who is not diabetic but has an untreated severe periodontal diseases. So that is just to summarize, periodontal inflammation produces so much. And there are studies that have said that, yes, insulin receptor 1 phosphorylation is very important for insulin sensitivity. But all these studies have been, done at a molecular level. And there is only one animal study which is done in rats, testing for the insulin receptor substrate 307. But in human, it is 312 equivalent to 312. But then no human studies are found. So my PhD kind of involves that, which maybe in the due course in a year, in 1 or 2 years when I complete, I'll present in the same forum if I'm given a chance. And moving on to this, look at the baseline and the 3 months value. The HOMA-IR is considerably reduced. And there are again studies that said that there is reduction following periodontal treatment in diabetic individuals. The same concept, the same pathway or the same mechanism can be applied here also. So it has brought down the HOMA-IR values considerably following treatment. So the periodontal therapy, even if it's just non-surgical therapy, has considerably improved the insulin sensitivity. So to conclude, I would say that there is a significant relation between insulin resistance and periodontitis cases were evaluated in this study, even in subjects who were not priorly diagnosed, subjects those who were not diabetics at all. It has put them at a pre-diabetic state. And there was also an improvement in insulin resistance following the periodontal therapy in case group. The only limitation which I would say is we did not try to attempt to find any dose-dependent relationship correlation between the disease extent or the HOMA-IR levels or the HbA1c levels here, because pretty much we took only severe periodontitis cases, so we thought that the correlation is not needed here. So with this, and Sangeeta ma'am stating that India is becoming the diabetic capital, we know that a substantial percentage of case population is at a risk for developing diabetes. And dental office reasonably is an, kind of a potential area to screen for diabetes or monitor glycemic controls. And here I think the first presentation, ma'am's presentation, to check for the diabetic levels in the GCF would come into role. So our role in early intervention and control of glycemic levels through periodontal treatment gains is very, very important. So, and thank you for this wonderful opportunity.
Thank you, Dr. Janani. It was a well executed presentation, I must say, and it was lovely hearing you. Thanks so much for your participation. Thanks, Snehlata ma'am, for chairing the session.
Thank you so much, ma'am.
Thank you.
Now we move on to the last lecture of the session and maybe invite Dr. Ajay Kumar Gupta as a chairperson for this lecture. Nankishore, Dr. Ajay's slides, please. Introductory slide. a privilege and once again an honor to introduce the medical faculty of the evening, Dr. Ajay Kumar Gupta. He is the director and head of the Department of Internal Medicine, Max Super Specialty Hospital, Vaishali. He's a scholar of American Diabetes Association and is a co-founder and medical director at Lotus Diabetes Private Limited and Madhumay Clinic, Mayur Vihar. Over to you, Dr. Ajay Gupta, for introducing the next co-speakers, two speakers you have to introduce.
Thank you,
Welcome,
Dr.
sir.
Sangeeta, and thank
Welcome,
you very
sir.
much. So we have this last session today, and it is on the detection of the odoriferous subgingival and tongue microbiota in diabetic and the non-diabetic patients with oral maladar. Because oral maladar is a very common finding in our diabetic patients. Means we find very many patients who are having odors. So this is to identify using the polymerase chain reaction. And for that, we have two speakers today, Dr. Vandana KL from Davangiri and Dr. Sapna from Davangiri. If I can have their slides, please.
Yeah, Nankishore slide introductory slide share kar de.
So first, Dr. Vandana. So Dr. Vandana KL is a alumni of Bangalore and of GDC Bangalore and BIOH, and she has done her MDS from Davangiri under the guidance of Dr. Devnath, and she has 35 plus years of blessed teaching in the clinical career, and she has got total Google citations of 2,933 with 23 years of research projects, and also she has the academic association with Dr. Cobbs Charles, Kansas University, US, as well as the Colgate Palmolive Probiotics and the gingival from sorry, Jen Gigel. I'm sorry for the spelling, for the pronunciation mistake, from Italy. Altis OBM from the South African University. So this is Dr. Vandana. And can I have the second speaker, Dr. Sapnas, please? So the second speaker is Dr. Sapna, and she is BDS from the CODS Davangiri in 2000 with MDS in parodontics from CODS Davangiri in 2006 under the guidance of Dr. Vandana. So she has got 104 publications in the scientific journals and 7 books to her credits, and with a total Google citations of 279 with the H index of 10, and she has got more than 12 guest speeches in the 18 scientific presentations, and she's actively involved in the organizing various events like the Oral Hygiene Day, the pre-conference for the ISP conference, and the walkathon for the creating the public awareness. And her areas of interest is the periosystemic link and the local drug delivery agents for managing the periodontitis. So I invite both the speakers to kindly present, and over to you, the speakers, please.
Nankishore's presentation share kar de.
Yes, ma'am.
Over to you, Vandana ma'am. Dr. Sapna, Dr. Vandana ma'am, please start the presentation.
Ma'am, I think ma'am, Vandana ma'am will begin the presentation and then I will take it over.
Is she there?
I just check, ma'am. Ma'am is not there.
Kindly start. Kindly start. Huh? Yeah.
I just asked, ma'am, if you, just a minute.
Yeah.
Hello.
Hello, yeah. Yes, Sapna.
Ma'am, I think there is some problem. Ma'am, ma'am
So,
is not able.
yeah, you just start the presentation. She will join maybe in between then.
Okay, ma'am.
Yeah?
Sure,
Start it.
ma'am.
Yeah.
Sure.
Yeah.
A very good evening to one and all. Okay. The previous slide, please. Previous slide. The topic for today's presentation is detection of odoriferous subgingival and tongue microbiota in diabetic and non-diabetic patients with oral malodor using polymerase chain reaction. Next slide, please. There are various reasons for which patients seek dental treatment. One of the most common reasons being the oral malodor. And oral cavity is the principal source of physiologic malodor. The most common method of assessing this oral malodor is by organoleptic method. And however, there are various methods available to check halitosis. One of the other methods, recent methods of assessing oral malodor is using a simple rapid chairside sulfide monitor, which provides scoring for the volatile sulfur compounds. And it is available commercially as Tanita Breath Alert, manufactured by Tanita Corporation, Japan. And various studies have been done using this instrument for assessing halitosis. Next slide, please. There are various studies been done where they have correlated the severity of periodontitis and volatile sulfur compound. And they have seen that there is an increase in subgingival plaque and gram-negative anaerobic microflora and periodontitis, which can lead to increased volatile sulfur compound. One of the main reasons for halitosis is the coating on the tongue dorsum. Why there is increased halitosis is because there is microbial metabolism causing putrefaction, which leads to halitosis. Next slide, please. Study done by Chang et al. Suggested that there's increased number of periodontopathic microorganisms, especially P. gingivalis, Treponema denticola, E. corridans, and C. albicans in both non-insulin dependent diabetes mellitus and non-diabetes mellitus individuals. As we now know that there is a correlation between halitosis and periodontitis, and we also know that there is a correlation between periodontitis and diabetes. However, when this study was done, before that, we didn't find any studies where they found correlation between halitosis, diabetes, and periodontitis. Next slide, please. Hence, the purpose of the present investigation was to assess the malodor using the organoleptic method and Tanita Breath Alert, where we quantify the odoriferous microorganisms such as P. gingivalis, T. forsythia, and F. nucleatum of both subgingival plaque and tongue coating of non-diabetic and diabetic chronic periodontitis patients using polymerase chain reaction technique. And this study is published in Indian Journal of Dental Research in the year 2011. Next slide, please.
Ignorant.
So coming to the methodology that we followed. Next slide. We included patients in the age group of 30 to 60 years of both sexes having chronic generalized periodontitis. Among these patients, 15 were non-diabetic and 15 were diabetic patients according to American Diabetes Association 1997. Next slide. We excluded patients who were suffering from other systemic diseases which are known to cause oral malodor, patients who had antibiotic therapy in the last 3 months, surgical or non-surgical therapy 6 months prior to the start of the study, pregnant or lactating mothers, and smokers. Next slide, please. So, it was an observational cross-sectional double-blind study where both the investigator and the microbiologist were blinded for which group the patient belonged. And patients were given certain instructions like refraining from using mouth rinses for a period of 24 hours prior to the examination and refrain from drinking and eating 2 hours prior to their appointment. And coming to the clinical examination, we examined plaque index, gingival index, and gingival bleeding index. Next slide, please. And malodor was detected by two methods. One is an organoleptic method, where the trained examiner will assess the odor, and then we use Tanita breath alert. Both of them detected volatile sulfur compounds and hydrocarbon gases. And the levels were measured as if no odor, scoring 1, slight odor 2, moderate odor 3, and strong odor 4. Next slide, please. Followed by this, we assessed even the tongue coating, and it was scored as non-visible coating as 0, less than 1/3 of the tongue dorsum surface covered as 1, less than 2/3 covered as 2, and more than 2/3 covered as 3. After this, subgingival plaque sample was collected from 5 to 6 sites with pocket depth of 5 to 7 mm, and sample was also collected from the dorsum of the tongue using a scraper. And both the samples were sent for multiplex PCR analysis to detect P. gingivalis, T. forsythia, and F. nucleatum, and samples were sent within 24 hours of collecting the sample. Next slide. The following statistical analysis were performed: Wilcoxon sign rank test and Mann-Whitney test, followed by Spearman correlation coefficient for comparing clinical and microbial parameters. Next slide. Coming to the results. Slide, please. Next slide, please. This is a table showing comparison of microbial profile in previous slide, please. Previous slide, please. Yes, thank you. So, a table showing comparison of microbial profile in non-diabetic and diabetic patients. Next slide. In this table, it shows that P. gingivalis count was more in diabetic individuals in both subgingival plaque and tongue sample. F. nucleatum was more in diabetic individuals in subgingival plaque, and T. forsythia was more in diabetic individuals in tongue sample. Other samples, there was no difference. Next table. Next slide, please. This is a table showing comparison between subgingival. No, the previous slide, please. This is a comparison between subgingival plaque and tongue sample in both diabetic and non-diabetic individuals. When subgingival plaque and tongue samples were compared, F nucleatum was significantly more in tongue sample in non-diabetic, and it was significantly more in subgingival plaque in diabetic individuals. And T forsythia was more in tongue sample in diabetic individuals. Next slide, please. This is a table showing correlation comparing volatile sulfur compound values with clinical parameters like plaque index, gingival index, GPI, and then also with tongue coating in diabetic and non-diabetic patients. This table showed that in diabetic individuals, tongue coating was correlated with volatile sulfur compound levels, and gingival index and gingival bleeding index were also correlated with the volatile sulfur compound levels. Next slide, please. This table correlates volatile sulfur compound levels with various microorganisms in non-diabetic and diabetic individuals. It shows that the levels of Fusobacterium nucleatum was positively correlated with organoleptic scoring in tongue sample, and TF was positively correlated with Tanita score in tongue sample in non-diabetic individuals. Next slide. This is a graph showing the correlation of various gingival clinical parameters like plaque index and gingival index between diabetic and non-diabetic. Next slide. This is gingival bleeding index in diabetic and non-diabetic. All the clinical parameters did not differ statistically between non-diabetic and diabetic individuals. Next slide. This is comparison of organoleptic assessment, Tanita score, and tongue coating between non-diabetic and diabetic, and we did not find any statistically significant difference. Next. Next slide, please. Coming to the discussion. Next slide. In the present study, we did not find any difference in mean plaque score, gingival score, and gingival bleeding score between diabetic and non-diabetic individuals. However, there are many, previous slide please. However, there are various other studies which gave contradictory results to these findings, like study by Khadar, Garsoy, and Lalla et al., where they showed, some showed that there is a significant difference between diabetic and non-diabetic, and some said there is no difference between diabetic and non-diabetic individuals. Next slide, please. In our study, we did not find any difference in the malodor levels and tongue coating between diabetic and non-diabetic individuals. However, in diabetic individuals, Tanita score had higher levels, whereas in non-diabetic patients, organoleptic score was higher in quantity. However, till the study was conducted, there were no previous studies where they compared these Tanita score and organoleptic scores in diabetic and non-diabetic individuals. So these results are presented for the first time in the study. Next slide. Coming to the subgingival plaque sample and microbes in diabetic and non-diabetic individuals. In diabetic individuals, in the subgingival plaque sample, P. gingivalis and Fusobacterium nucleatum were higher in quantity, whereas Stanarella forsythia did not show any difference in diabetic and non-diabetic individuals. Next slide, please. However, when we searched literature, we found various different types of results. Like some said there is a correlation in microbial profile in diabetic and non-diabetic. Some results showed that the microbial profile was more in diabetic compared to non-diabetic. And some found out that the microorganisms were lower in insulin-dependent diabetics compared to non-insulin dependent diabetics. So, this literature review reveals an inconsistent microbial profile among diabetic and non-diabetic groups. Next slide, please. Next, when we compare tongue samples in diabetic and non-diabetic, all the three organisms that we try to detect were higher in diabetics compared to non-diabetics. However, P. gingivalis and Fusobacterium nucleatum were higher among all three in non-diabetic, and in diabetic, Fusobacterium nucleatum count was higher in subgingival samples in diabetic patients. Next slide, please. P. gingivalis and Tannerella forsythia were higher in tongue samples than subgingival plaque samples. However, study by Van Winkelhoff in 1986 showed that the microbial flora found in subgingival plaque and tongue coatings, they were similar. There are no consistent results found in the literature regarding comparison of subgingival plaque with tongue microbial flora. Next slide, please. Studies done by Dioh said that the tongue flora is similar to the flora found in subgingival plaque. However, when we search literature, the large variability is found in the flora of tongue coating, and this variability could be due to difficulty in obtaining a standardized sample of the tongue flora, as tongue is soft, highly mobile and flexible structure, and also the amount of sample that we are going to collect from tongue may differ. And also the tongue flora may change over time within an individual, leading to variability in the microbial flora in the tongue sample. Next slide, please. In this, tongue coating was collected and it was assessed by organoleptic assessment. However, it cannot be ruled out that the acetone breath that is found in diabetic individuals might also have led to the malodor in these patients. And when we assessed gingival index and gingival bleeding index and correlated with malodor, there was a significant correlation between these parameters and malodor. And also there was a significant correlation between tongue coating and malodor estimation. Next slide, please. The equipment that we use, that is Tanita breath alert, gives digital reading and it measures only volatile sulfur compound. Hence, we also use organoleptic measurement. However, to prevent inter-examiner variability, organoleptic assessment was done by a single operator. However, it could not have discriminated between volatile sulfur compound alone or if volatile sulfur compound was combined with acetone breath in diabetic patients. And when we compare microbial profile with volatile sulfur compound levels, Fusobacterium nucleatum was significantly correlated with both organoleptic and Tanita score. Next slide, please. So some studies, they displayed Tannerella forsythia increasing in malodor subjects than healthy controls. So various and different types of results indicate that increased diversity of species in halitosis suggests that halitosis may be the result of complex interactions between several bacterial species. However, there are no comparative studies exist in periodontal literature correlating the relationship between subgingival and tongue microbial profile and volatile sulfur compound levels in diabetic patients. Hence, this could not be correlated. Next slide. To conclude, next slide please. The dental research community has long ignored the subject of, previous slide please, the oral malodor, previous slide please. And to find out the effective treatment and to find a solution for the patient is also difficult. However, the old standard technique of tongue brushing should be encouraged and patients should be motivated to follow tongue cleaning regularly. Next slide. These are my references. Next slide. Firstly, I would like to thank my teacher, my guide, and my mentor, Dr. Vandana KL, for believing in me and giving this opportunity to present this study. Next, I would like to thank Dioh team, Dr. Sangeeta Dher, Dr. Sunita Bansal, and the chairpersons for today, Dr. Ajay Kumar Gupta, for providing this platform to present this study. Thank you, one and all.
Thank you, Dr. Sapna. Dr. Vandana, would you like to add a bit on the study, please?
Yeah, more than to add, I should first apologize.
Oh, it's okay. It happens. Technical glitches.
Technical glitch, and then it happened to me at this time which I had to speak. Now, first of all, I should thank Sapna for a smooth and a quality presentation. I think all of you enjoyed it, and she is my, of course, a Quartz Perio alumni. I'm always proud, like Sangeeta, who has also been a chairperson for this, who is taking over quite a bit of diabetes and periodontitis and the oral health all over, and let this grow. And I should also thank immensely Dr. Ajay Kumar Gupta, who is a medical fraternity, and he was trying to introduce us. And I missed that opportunity of listening, but of course I'll go back and listen to it. And then the gingival was a study which was done by Sapna for me. Quite a few, as the time goes, I have been a part of the word former is only former, but I'm still an academician with a lot of research projects taking up. And I'm initiating the periodontal research and then trying to go ahead with them. Whoever is interested can always be with me. Sangeeta, you can share the email of mine so that I just wish that our subject should grow well. And it should grow well to that extent that we should reach most of the public around and the people around and the researchers around. And you have been doing a good job for this, along with Sumedha and your entire team. I enjoy this. And then I wanted to say, as a Quartz Perio alumni, as a teacher, yes, I've been always proud, and you have done a good job today, and I think you will continue to do it. And Sapna, immensely thank you for all the support you gave me, and you took over my part of presentation. Okay, and nonetheless, I really appreciate. Okay, thank you so much, Sangeeta.
Thank you, ma'am. Thank you so much.
Yeah, and all of you who were here on the platform. And I really thank one and all for listening to it, because this is a very, the study which was done in early 2000, but got published in a very reputed journal then, because I would say it's a PubMed journal without payment. Now it is a paid journal. So the concept of payment and getting it done is getting dilution with the, I would say I shouldn't continue, but still I would always be open up. It dilutes the standard of the work and then getting published. So whenever you have a time to do, see, that's the time. We almost had 3 years to go ahead with this paper making. And it was from Journal of Dental Research from India section, and proud to be a part of it. And always giver to the learner, and to the best of the knowledge which we could share. So I wish all of you all the best, And then the crux of the study, is quite deep. We have two more methods, organoleptic, which is very cumbersome. All of you know that. I don't think most of you would have experienced this, because you need to put your nose towards the patient's mouth, and how ugly it could be to as a scene. As a researcher, yeah, we had to do that. And then organoleptic was also being measured with the VSC production, which is tapped by Tanita Breath Alert, a newly introduced Tanita Breath Alert is a malodor measurement, which is still produced by the Japanese company. And thanks to that, because we stopped using organoleptic now. That is one takeaway home. If you want to measure anything as a malodor, you can take Tanita Breath Alert, and then it can definitely measure a VSC, which is produced by the periodontopathogens. But however, we are not talking about acetone breath here, because that's not a part of this study at all. And various organisms, we could do it with PCR, and two measures from the tongue and from the subgingival microflora. So it's quite an extensive study with a lot of correlation. I hope you all got the message. And then there is various authors to support, also to contradict. This is because one thing I'll tell you, that there is always a bias in selection of the patients, and basically that's what happens. And also the periodontopathogens vary in their presence in the subgingival plaque as well as in the tongue dorsum. This, to standardize, it's very difficult. Okay, so anyway, thank you so much for giving me this much time and to speak on this, and thank you one and all. All the best.
Thank you, Vanda ma'am, for the words of wisdom, which is always encouraging and opportunistic. So now we move on to the last leg. That would be a summarizing version of the whole webinar by Dr. Anurag Satpathy. Dr. Gunjan, could you please introduce? Okay, I think she's facing little glitches. Okay, Nand Kishore, please share kar dijiyega Dr. Anurag ka introductory slide. Okay, allow me to introduce another DOH active member, Dr. Anurag Satpathy. He is a professor in the Department of Periodontology, Institute of Dental Sciences, Shiksha Anusandhan, Bhubaneswar, Odisha. He is graduated from the BVP Dental College and did his post-graduation from SDM Dharwad in 2007. He is an ardent researcher and speaker with research interests in tissue generation, biomaterials, periodontal medicine, peri-implant disease, and platelet concentrates. He has over 100 public index publications and is a reviewer of several journals. He is a PhD in dental sciences with pioneering work on biomimetic textured GTR membranes. He has filed 2 patents, one of which has been granted, and has contributed as a lead author in book chapters with Springer Nature and Elsevier publications. Anurag is a practicing periodontal surgeon and is in charge of the Integrated Department of Oral Implantology at the IDS SOA, University Bhubaneswar, Odisha. Over to you, Dr. Anurag, to sum up the proceedings.
Thank you, ma'am. A very good evening to all. At the outset, let me thank you all researchers and academicians and clinicians who have given their valuable time to share your own research work here. The whole idea about gathering here on this webinar is that we wanted to bring together the work which has been done on diabetes and periodontal disease in India. Now, the focus is that not much work is being done, or whatever is being done, let us see where we can move forward. I'm thankful that we could find some studies with your enthusiastic participation, and you presented here. Thanks to the leadership of Sangeeta ma'am and Sumita ma'am here. Now, to sum up, thank you, Dr. Nima, for this wonderful study that you had presented on GCF. And yes, now we are definitely moving forward for non-invasive tools. And if we are able to correlate further the GCF and blood glucose level and come out with accurate levels of this marker, we can still have this commercial kit available. But so far, so good, it has not been seen. But I hope that we move in this direction forward. And your study has been one good step forward in this direction. Thank you for this for sharing this study, ma'am. Thank you to Dr. Anup Bhushan for patiently giving her inputs and chairing this session. I move on to the next study where NLRP3 was presented, and it appears that it is down-regulated in the periodontitis independently to the status of diabetes. Now, yes, this is another significant study, although not much of significant results were found. But yes, we need some studies which go into the molecular biology and understand the mechanism behind the two-way correlation. We often say that periodontitis and diabetes mellitus both are related in a two-way form. But as and when the technology improves and we have more advanced techniques and tools, we will find more clarity in this relationship. And the research work on the inflammasomes in this area is a good step forward. I think there are more studies which people are taking up in inflammasomes and periodontal disease now. And if we look at the cohort, especially where the diabetics are present, it would unravel more mysteries. Thank you, Dr. Gunjan Gupta, for chairing this session and giving your insights. Next, Dr. Janni Mothu, thank you for sharing your study, ma'am, on the very less explored area of pre-diabetics. Now, yes, diabetics and periodontal disease has much been studied, but the cohort which is often missed is the pre-diabetic area. And a wonderful marker of HOMA-IR that you have taken is also not very conveniently taken, because we mostly go in for HbA1c level or RBS levels. But if we can catch them early, as you have shown in your study that there is a relationship, and also the latest research shows that there is good amount of association between the HOMA-IR and diabetes. So if you can catch them early, then that would be a good step. And I wish you all the best for your PhD work and more such good insights into your work. And I thank Dr. Snehlata Verma, who have chaired this session, our friend from the medical fraternity, for your insight, ma'am. Your presence here is an appreciation that we also have our friends in the medical fraternity who are supporting us. Next, I come to this study, and none other than Dr. Vandana, who has chaired this study, and thanks to Dr. Sapna, who presented this study, particularly looking at the odoriferous bacteria, both in the subgingival as well as the tongue coatings. Now, we have seen that, yes, there is a difference in these, but as per the study, the F nucleatum and Tenerife forsythis were the only ones which were showing significant differences. And we have gone ahead of using the organoleptic methods, as Madam rightly said. We have newer tools like halimeter and the tools that you have used, and or the breath odor with the diabetic levels. If we can do that, probably we can also have another non-invasive tool and not go in for finger prick methods. And also the kind of microbial differences that we have, it also underlines that a targeted microbial therapy is required for the particular cohort when the person is diabetic, as well as have these kind of bacteria, which we often stress on. Thank you, Vandana ma'am and Dr. Sapna, for presenting this wonderful work. And thank you, Dr. Ajay Gupta, once again, sharing your time with us and encouraging and inspiring us for this. So I think with this, we come to close of this wonderful symposium, and we would also request you to continue the work and be a partner, because we need such more studies from the Indian scenario. We get to know a lot of work from across the world, but the Indian cohort is a different, and our cultural socio-economic backgrounds are different. And probably we need more such data, and in a compiled and consorted matter where we can come up with some conclusions. I think with this, we close this session, and I am thankful to Sangeeta ma'am for chairing this wonderful symposium. Once again, I'm giving this opportunity. Thank you.
Thank you, Dr. Anurag, for summarizing the whole show. And actually speaking, I'll share a bite. When we were supposed to, conceptualize this webinar theme, we were quite skeptical, discussing among the scientific team members that should we not. And we are really happy that we had invited participations from all the members. And to our surprise, there were many publications that were sent back to us. And from the screening and the scrutiny, we could filter out some few of them. And we are so thankful to all the participating speakers who have actually shared. And DIOH actually looks for volunteers for collaborating, partnering, and the show must really go on, because DIOH is the only platform in the country that is actually talking about oral health and diabetes continuum. So thanks to Diabetes India, I must say, for having that vision and giving a platform to we the periodontists to take this baton forward. So thank you so much all for participating. Till we meet again next, maybe in another capture of such sort of webinars again. And we look forward to seeing you and meeting again. Delegate participation, I'll be just putting in the chat box, and your participating felicitation certificates will be sharing with you all the speakers as well. So thank you all, and good night for now, and we meet up again.
Thank you,
Sangeeta.
Thank you, Sangeeta ma'am.
Thank you so much, ma'am.
And thank you, RX
Thank
event
you.
also. Our pillars in conducting these shows, RX event. Nand Kishore ji, बहुत धन्यवाद.
Thank you, ma'am. Thank you, ma'am.
Thank you so much.
And
Delegate.
about Anurag's summarization of each study. He's actually heard and summarized each one so nicely. Thank you.
Thank you.
Yes, Anurag. Yes, it was a good.
It was good meeting you here after a long time, sir. Yeah.
Yeah.
Thank you.
Anurag did a good job of summarizing at one point of collecting so many informations from such wonderful studies. Okay, thank you, Anurag, and always, yeah, you are a part of Springer Journal. I think I had a reviewing and I think I could not do it. I had apologized. Okay, all the best. Thank you.
All of you. Thank you so much. Till we meet again. Bye-bye. Good night.
Thank you, ma'am. Good night. Bye.
Bye.
Thank you, ma'am. Bye.
Bye. Bye.